Hello, everyone. Welcome to the first affiliate hospital of Harbin Medical University in Heilongjiang Province, China. Once again, I am privileged to be the moderator of the current case. I am Dr. Cao Yang from the cardiovascular department. And today we are going to work on a very complex CTO case with the RAD totally occluded. And next, please allow me to introduce the leading operator of today, Professor Li Yue, who is the vice president of our hospital. And today we are going to demonstrate this very complex CTO case, who is also on a second attempt this time. And next, I will give the time to Professor Dong Guo, who is also the second operator, and he is going to introduce the general information of this patient. Please, Dr. Dong.
Okay, thank you. First of all, let me introduce the operators and the moderator of this case. First operator of this case is Professor Li Yue, and second operator is Wang Dingyu, Zhiyu, and me. Moderator of this case, also Professor Cao Yang. Next. This is a 41-year-old male and suffer from chest pain for 5 months. Risk factor are hypertension and diabetes for two years. Injection fraction is 70%. Next. Next, please. Okay. Laboratory data almost normal. Next. This is electrocardiogram. From this picture, you can see a Q wave in these V1 to V4 and elevated ST segment in these 3 and AVF. Depressed ST segment in these 1 and AVL. Next. This is angiography on February 4th. From this picture, from this meeting, you can see there's a stemless CTO lesion at proximal LED, and you can see there's then in the circumflex. And next, and this patient did the circumflex standing operation about 3 years ago. Next. About 50% stenosis at the distal circumflex. Next. Next. Move, please.
Okay.
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 Yes.
Doesn't matter. Just introduce.
Okay.
Yes.
Let me introduce the right coronary angiography, and this
Next slide, please.
Okay.
If
It's
the
jam.
PPT don't work, we could see today's Andrew. Okay. Okay. Let's see today's Andrew. Okay. Go on. So the slides. RC. Okay. Thank you.
Okay. This is a right coronary artery angiography, and it's very long, diffuse, mild stenosis of right coronary artery. And you can see there's some contralateral to support the RAD, just like PL maybe, and there is a set branch from the proximal right coronary artery to support the left anterior descending. Okay, next. Next, please. Next, please. Okay. During the last operation, the operator planned to treat this CTO lesion with an integrated approach, and the operator used Gaia second, Gaia third, and Conquest Pro to puncture the CTO proximal cap with the support of Corsair microcatheter. Next. However, unfortunately, the guiding wire failed to enter the distal true lumen. Next. Okay, this is the final imaging.
Okay. Dr. Cao already introduced baseline information of this patient, and we already know this patient is a proximal LED total occlusion, and should be a small stamp here, but with severe calcification.
Mhm.
And the length is, I think, more than 20
Yes.
millimeter. And the patient, we could see today's angio. Please show today's angio. So we can see the patient with anomalous
Mhm.
RC osteum.
Mhm.
And certainly, this time we also use our artificial intelligent visualization system to
Mhm.
okay, go back to the CTA, please. So use AI visualization system to reconstruct the patient's CTA. But very interesting, as we know, CTA sometimes also the accuracy couldn't be
Mhm.
100%.
Yes. Mhm.
So the CTA told us the ADD is patency,
Mhm.
but we can see that is the reconstruction of the CT imaging. But we already did angiogram. The IDD is still occlusion. So
Yeah.
showed us really CTA has some limitation,
Mhm.
but it's not the limitation of the artificial intelligent visualization system. This
Mhm.
is because of the baseline data.
Yes.
The baseline data told the AI system, so the IDD is patency, but it doesn't matter. We could know clearly the distribution of the lesion and the vessel. Okay, let's see the CT reconstruction imaging. Wrote a little bit to the RO caudal view. RO, oh, okay, that is the epicranial view we can see. So the reconstruction showed its patency,
Mhm.
but really it is, in fact, it is occluded. But we can see severe calcified lesion in the proximal IDD.
Yes.
And only a little bit soft plaque. Most are calcified lesion. This is why the first time a very well experienced operator, CTO operator, couldn't successfully recanalize the CTO lesion. Okay, and could we delete the brown soft plaque? Let's enlarge a little bit the imaging. Enlarge, okay, move a little bit. We can see very clearly the calcified lesion distribution. And there should be a small stamp just at the ostium of the diagonal branch. And certainly, I think the cap is should be very stiff. And the first time, the operator used CP wire finally to make the wire come to the CTO body, but still couldn't come to the distal lumen. And after in the distal part, just at the diagonal branch area, there is no large calcified plaque. Okay, let's move on to today's angiogram. Okay, let's see today's angiogram, please. Okay, this is the first angiogram. We can see this is really anomalous ostium RCA, and we use one femoral and one video approach. This is really a very big guy, very young but a very big guy, patient with OSAS. And the RCA angiogram, we can see some collateral channel to the distal RCA, and with diffuse lesion, especially in the should be in the third portion segment. There should be some maybe a relative unstable plaque there. We can see clearly. So if we use retrograde approach, we may firstly use imaging to check the place and may implant, maybe implant a stent there, and to make the retrograde approach is
Safety.
safe. Okay. And let's see another view. This is the RO view. RO is often used for us to check the collateral channel, separate collateral channel, but we can see we couldn't see very clearly. In order to better do the RC angiogram, and finally we use Godzilla to a little bit deep engage to the RC ostium and the RO view, we can see no very good septal channel. There should be a relatively good septal channel, but the exit point is very close to the distal fibrostic cap. And this is the bilateral angiogram RO cranial. We can see the occluded segment and really the LED with calcification. And we can see in the middle portion of the LED, just at the diagonal branch area is patency, but before the diagonal branch with some plaque. And okay, let's see the AP view, and we can see okay. So for this case, we should talk about discuss the strategy. So certainly we could sometimes try retrograde approach, but we must check the RC first to see if there is a steeple plaque or severe stenosis. But there is no very good septal channel. So certainly for that case, I think we may try antegrade approach first. So the first time the antegrade will also the antegrade will come to the LED architecture, but maybe should be in a spiral style. That means the wire in the media in the subintimal space couldn't come into the distal lumen, and during the course of the wiring spent a long time for the operator. So that time, because with the CT reconstruction already showed us severe calcification. So I think when the wire come into the CTO body, we may use knuckle.
Yes.
Use knuckle technique, and then we may try ADR. This time we may try ADR. But next question is, where is the optimal reentry zone? So certainly the reentry zone should be with larger diameter, with the lower the plaque burden, the better. But we can see there is a big diagonal branch.
The second
I
one.
think the optimal reentry zone should be proximal to the LED. But really, in the proximal LED, there is some plaque burden in the LED area. So this is a difficult point. Okay. So the left coronary tree we use EBU 3.75 guiding, and this is the RO caudal bilateral angiogram, and we can see just at the ostium of the LED, the proximal cap, there is a diagonal branch and should be a septal branch.
Yes.
So two branch. So that may cause the wire easily to slip into the side branch. And many times manipulation may cause the dissection of the side branch. If the diagonal branch was injured, may cause severe ischemia symptoms. So we must be careful. And this is a spine view. We can see the distribution of the diagonal branch. And firstly, we like to put a workhorse wire in the circ to keep the whole system stable. And Cosia microcatheter was used, and use because this is demo, we showed the audience use workhorse wire and use Gaia third wire, but we can see often slip into the diagonal branch.
Yeah.
Okay, so that means the fibrostic cap also is very hard, and because of with several side branch, it's difficult to puncture. So sometimes we may try a Eurolumen microcatheter, and this time we can see the wire go into the septal branch, and this is the wrong direction. And in the RL cranial wheels, and last time we uh, ship large angle uh, with a relative long distance to make a large angle, long distance for the
Second curve.
stiff wear. Okay, make a second curve to make it would be puncture to the LED, but we can see even the Gaia third wire slip into the diagonal branch, very stiff. And even with Corsair and with aid of the Sasuke, still couldn't puncture it. In order to make sure the outcome of the LED, we did IWAS. Okay, please show the IWAS. Okay, the last to run. Okay. Okay. Dr. Chao, you could interpret the IWAS imaging.
Okay, like Professor Lee just introduced, that it's a blunt tip and also a relatively big vessel of the proximal cap. And we make a pullback from the big set branch of the big DAG to the proximal part of RAD and left main to engage and make sure what's the proximal path and best entry point of this CTO lesion. So this is a manual pullback from the diagonal, and we can see it's a relatively very big set branch, which means that we need to keep this very important set branch patency to ensure the prognosis of the patient. And as the IVAS caster is pulling back, we can see that from the 4 o'clock to 6 o'clock, there is a main LED vessel joining into the set branch. And from this one, we can see it's the LED occluded segment. And also here is some hint for our next procedure. First, it's a very big LED vessel. It's joining into the set branch, and also at the opening of the set branch from the CTO segment, it's very clear. There is almost no plaque. Second thing is that there is some mild calcification on the side of the occluded LED, so which may cause some problem to the antegrade puncture during the next antegrade procedure. And here we can see that this is the occluded LED. Here, this is might be the entry point of the CTO segment. This is what we can see from the IVAS, Professor Lee.
Okay, let's go back to the PSC. So really, we use IWAS to make sure that really the direction is right. The CT reconstruction already showed us the right direction. But how to make a stiff wire come into the proximal cap? And there are some tips and tricks. First, we should deep seat a little bit the guiding to make the guiding the tip toward the LED. And next, in most conditions for this kind of case, we should need relative stiff wire with taper tape.
Yes.
And should with a relative large second curve. And sometimes, even we use very stiff gap wire, we still couldn't cross the fiber stick cap. We could use balloon deflection technique. That means in the diagonal branch, we inflate a 1-to-1 diameter balloon and to assist the wire to come to the LED. But this time we use CP12 wire and make a large second curve. And in that direction, we rotate very carefully. We can see this time the CP12 wire may come into the CTO body, but we must use another orthogonal view to recheck the direction. Okay, in that direction, we advance a little bit the stiff wire. We must give enough support to make the microcatheter would come into the CTO body. And then the Corsair was advanced to the proximal portion of LED. But when we try to use de-escortation the wire, but we found the wire may come into the subintimal space and look like spiral sheet. So what we should do next, I think we may use the knuckle, knuckle technique.
Knuckle technique,
and
yes.
we already use field XT wire. We know field XT wire, the tip is very soft and we make the umbrella
Mm.
curve
Mm-hmm.
in the tip,
Mm-hmm.
and uh,
It's like a U curve.
make the OCX microcatheter very stable.
Mm-hmm.
Okay, we saw the wear and try knuckle wear. Let's see if that time the knuckle wear would be successful. We must be careful because we only advance a little bit the cochlear microcatheter. If with strong resistance, we go back to the diagonal branch.
Yes.
So
Mhm.
we must be careful.
We can see that Professor Li is performing the knuckle technique using an hydrophilic coated wire. And actually, I think that this is a very dramatic CTO case with a blunt tip of the proximal and occluded LED. There are several things that I think that we need to discuss in full details. First thing is that I think this one is a JCTO score 3 case. There are several things. First, it's occluded segment is over 20 millimeter from the CTO reconstruction and also from the
So at that time,
lateral angiography.
I think we
Mhm.
already did knuckle.
Yes. Uh-huh.
So the antegrade contrast injection should be avoided.
Yes. Yes.
Yeah.
Mhm.
So we should use a contralateral
Yes.
angio. Okay.
To avoid the potential antegrade dissection and
Okay.
hematoma, which means that from now on, the angiography from the antegrade should be avoided.
Okay.
Yes, I think the knuckle wear has been very near to the distal.
So because also we use very soft hydrophilic wire to make the
Mhm.
knuckle.
Yes.
The knuckle should be relatively smaller than like pellet,
Mhm.
150 or 200.
Mhm.
The wire, but still make a relatively large
Mhm.
dissection the pseudo chamber.
Mhm.
And at present, we should not advance too much the the, the knuckle wear and advance the cochlear microcatheter.
Mhm.
And in most condition, because uh, we already use the knuckle to make a large chamber, the cochlear could be easily advanced.
Mhm.
And certainly the stingray blown could be advanced
Yes.
relatively easily. Okay, give me a Miracle 12, please.
Okay, so that we switch it's a I think it's a Fielder family where that's switched to a Miracle family where, and next we are going to proceed with the ADR and the strategy. I think
Miracle
there are
12,
several
please.
things that we need to discuss. Just like I mentioned that this is a JCTO score 3 case. There is some diffuse calcification with the proximal occluded segment, and it's a second-hand case. We know that there is a previous attempt 3 months ago, and also that we may notice there are several very important set branches near the occluded segment. And we all know that there is a bifurcation near the proximal cap. It's a very strong predictor of antegrade failure because we know that from the antegrade parallel techniques, the wire may easily goes into the patent set branches, and also after the antegrade attempt may cause the severe damage to the ostium of the set branch. And also there is inability to wear the occlusion due to the preferential gatewire entry into the patent branch and the failure to engage the CTO. And also balloon inflation in the set branch or non-inflated balloon can block the wear. So this may be some tricks for the antegrade wear escalation during the plant tip of the proximal cap. And also, like Professor Li just did, we used a dual lumen macrocatheter to try to help us to perform the antegrade wear escalation approach. However, we may notice that this dual lumen macrocatheter failed to guide the antegrade wear into the true lumen because we found from the CTO reconstruction information and also from the bilateral angiography that there is a very big size of the proximal entry point, and also there is some calcification, which all raise the difficulty of the antegrade wear escalation. And since that, we noticed that there are several questions involved from the anti-grid approach. One question is that what is purpose, how to the strategy of the anti-grid wire escalation? First, we noticed that Professor Li used an Gaia third wire and switched to a Conquest Pro, and later it's a Conquest Pro 12. And eventually we used the Conquest Pro 12 to engage to the proximal cap of the CTO segment. And then later we are switched to this kind of ADR techniques because due to the relatively not so long occluded segment. And another very important information is that from the 3D reconstruction and also the bilateral angiography, we found there is no important set branch within this CTO occluded segment. When we are mentioning the so-called important set branch, we usually means that this set branch is performing over 10% of the left ventricular myocardium, and also we can judge from the length of the set branch and also the diameter of the set branch. Majority of the times when the set branch diameter is less than 2 millimeter and also the length is less than 60 millimeter, I think that is relatively small and doesn't cause very severe damage during the crossover and loss of the set branch. And we may notice that there is a second set branch, second diagonal near the distal, cap of the occluded segment. So as Professor introduced, we should avoid to lose this relatively big second dag during this ADR techniques. And there is a question from the audience that is the purpose of keeping a wire in the arterial branch is to increase the support. Yes, you may notice that the opening of the RCA is not a normal site. It's the opening of the ostium of the RCA is to the, goes to the up. So you may notice that we are using an gazilla as well as a wire in the arterial branch to increase support and also to keep and maintains the coaxial position of the RCA guiding catheter to make sure that the flow is enough for the bilateral angiography as well as to increase support to make the whole system stable. Next one, are any of the gate wires that you are using made in China? Yes, we have gate wires that 100% domestic. And currently, the wire that is in the RCA and also later the working horse wire we have is a 100% domestic wire. Does the software calculate the GCTO score automatically? Currently, no, we didn't add this kind of function. There are several things that we do not do this one. One thing is that GCTO score is relatively easy to calculate. It doesn't spend too much time. And the second thing is that we believe GCTO score is a relatively important predictor to predict the successful rate and also the planned procedure strategies. However, there are several other scoring systems that is also useful. So maybe automatic calculation of the GCTO score for the software is not that necessary. We may notice that there is a so-called the CT rector score using the CTO angiography, image to calculate the difficulty of the CTO lesion. For example, we can grab some CTO angiography image predictors like the occlusion length, the duration of the occlusion, whether it's a multiple occlusion or not. These kind of predictors to better predict the 30 minutes wire crossover successful rate, which might offer more information for our strategies as well as to predict the procedure rate. Is the 3D reconstruction software built in Harbin? It's built. Yes, thank you. Yes, this software is 100% domestic, and Professor Li is a leading developer to read this software as well as multiple function. And as you can see that during our previous demonstration, no matter it's a CTO case, which means especially we use it in CTO case, it can offer very detailed information of not only the vessel structure, but also the composition of the plaque, as well as the distribution of the plaque, which offers very, great importance during the strategy of the CTO case, because you can see very detailed information with this kind of 3D reconstruction. What's more, you can interact with this software. Just like the demonstration of Professor Li, you can delete the non-important structures like the rota, the RCA, this kind of, non-target vessels manually. You can interact with this software to see what you want to see from this specific and very detailed angle that you choose. So this is the beauty of this software. And
So in China, we, in most conditions, we use Corsair and the Stingray balloon combination. We don't use the crossbows. Yeah. So the Corsair already been advanced to the target lesion. Strictly speaking, the target lesion is not a very optimal place because should be a little bit calcification lesion.
yes.
But because we try to see the diagonal branch, okay? So let's try if the stingray balloon could be advanced. Okay, Dr. Cao, you could go on to.
So we can see that Professor Li is working on the ADR techniques. There are several issues I think that we need to clarify during the ADR techniques. For this case, although it's a LED occluded segment, we can see that we may try our best to avoid all the important set branches. So this is I think that's number one. How to say that information that offer support us to perform the ADR techniques. And the second thing is that we can see that the anti-grid knuckling techniques successfully, goes to the distal part of the occluded segment, very, next to the distal cap. And also that why we do not try to perform, the cross-pulse catheter to try to engage to the distal part of the CTO segment. There are several things. First thing is that I think knuckle wear can relatively cause less damage to compared to the crossballs, and also like this kind of calcification cases, I think that it's relatively easy to engage to the distal cap of the CTO segment. And the next thing is that during the delivery of this stingray balloon, we can see that Professor Li has just delivered the balloon to the relatively optimal site. To try to re-entry to the distal true lumen. And now we opened this stingray balloon to relatively low pressure. It's a full atmosphere, I think.
So the balloon must be well prepared. Sometimes if the balloon was not very well prepared, we couldn't see the balloon. And the optimal view, the stingray balloon should be one line. Let's choose, okay, choose a view to make the stingray should be in one line here.
Yes.
Okay, could we see? Okay, here should be in one line. Okay.
So we are choosing the right projections to maintain that this balloon, the bilateral side into the one line.
Yeah, okay.
To choose the perfect puncturing direction.
And we routinely use palm to be straw. Also, there should be not a large chamber, pseudo chamber, but we still use palm to. Yeah, okay. Sometimes we can see some black flow by. Last time, I think no big hematoma.
Yes.
The more calcification the lesion, the less the formation of the hematoma. Okay.
Yes,
At
and
that
also,
time, I think we should make a contralateral angiogram. Okay. To make sure where is the direction of the true lumen. not very clear. Okay.
Yes, because we know that this case doesn't, gives a very, good collateral flow from the RCA, vessel to the LED. There are several collateral flows from the RCA to LED. One is from distal RCA, and one is from the proximal arterial branch. However, we may notice that either of these collateral flows doesn't offer, big enough and also good enough collateral flows to the LED. So which, is another, thing that when we perform the anti-grid ADR techniques, not the retrograde approach, because the distal RCA situation is poor. There is long diffused plug, and also the collateral flow to the LED is not so clear. The collateral flow is not, well enough to support the retrograde approach. So maybe now that we try to, push the balloon a little bit further, maybe.
Let's try here.
Mm-hmm.
If still couldn't work, we
Mhm.
may
Okay.
bobsled advance to
Okay.
the distal portion.
Mhm.
The proximal, the
Mhm.
better.
Yes, yes, yes,
Try to avoid long segment.
yes. We just mentioned that we want to keep the distal side branch patency. And you may notice that this stingray balloon has two markers, and also that we know this stingray balloon has two, exit point. Each of these exit point is on the different directions. So we can see that with the right projections, we may clearly, see that this bilateral, contrast visualization line is on the same side, is on the same level. So which is a guarantee of the good projections to observe the direction of the puncture wire. So as we can see that we are using the wire to try to puncture through, how to say, the vessel architecture. Also, we say that it's
please.
within the subintimal space to re-entry into the true lumen. The direction is very important because we know that with retrograde angiography and also some information that we acquire from this 3D reconstruction, that the puncture direction is of key importance to the success of the following procedures.
A little bit of cough of the patient.
And also another very key information to the success of the ADR techniques is the control of hematoma. We know that the antegrade hematoma sometimes may cause some difficulties in the position and also the control of the stingray balloon. Just like Professor Li introduced that, as well as that we have, successfully make the knuckle wear, engagement, we need to avoid the antegrade angiography to avoid any, potential hematoma and the dissections.
Pilot 200, please.
Okay, Professor is switching to a relatively stronger wire, the Pilot 200.
So, because we couldn't see very clearly the tournament, the direction, so we, from the two-side hole, test the puncture, so-called double blend, taking the swab, but we should not advance the wire too much in order to avoid large hematoma formation.
Yes.
If this please doesn't work, we may advance a little bit the stingray balloon relative distal portion.
So we are going to try the second swap strategies. For the antegrade stingray ADR techniques, the puncture, I think that the curve of the antegrade, the puncture wire is relatively important. For my experience, relatively small, for example, and a 1 to 1.5 millimeter long, and a 30 to 45 degrees, curve of the distal band, I think is preferred for the CTO segment. There are several things that why we form this curve like this one. First one is that we try to enhance the penetrating capability of the guide wire. So a relatively small curve and a relatively, how to say, and a small curve and a really short tip is a guarantee of a good penetrating capability. Second thing is that it can reduce the likelihood of deflation outside the vessel architecture or into a side branch raising into the occlusion. This is of key importance, especially in the ADR techniques like the stake and swap strategies. So creating such a small band, like I said, it's a 1 to 1.5 millimeter, 30 to 45 degrees, band, can only be accomplished by inserting this guide wire through an introducer, like Professor Lee is working currently. So we want to try to avoid to make this curve, especially an anti-grid CTO wire curve, using the side of the introducer. So we strongly, suggest you to insert this guide wire and use the tip of the introducer to make this curve.
No need.
So from the CTO 3D reconstruction, we noticed that the relatively CTO segment length is 20 to 25 millimeter. And also what causes the predictor of anti-grid failure, from the previous attempt, there are several diffuse calcifications as well as some diffused very large block burden. So which may cause the anti-grid wear escalation, difficult because you may easily go into the sub-intone space. Although it's within the architecture, so it's high likely that you, engage too too far with the parallel techniques. It's high likely that all these wires, so keeps
No
into the
balance
subintimal,
200.
keeps into the subintimal space to a very long, distance until the distal, true lumen site. But you cannot re-entry into the distal true lumen. So this may
Good, I
cause
see
to a
it.
very long and
Good, I
big
see.
hematoma to cause the damage of this retrograde,
New palette
polytoral flow.
200.
So
Okay.
this kind of situation is a very strong predictor to the peri-procedure myocardial infarction. So we want to try to avoid this one. So this is why some, doctors try to the spam techniques and also to perform investment for this kind of relatively, difficult blunt tape and the relatively long CTO procedure.
So we can see the palette 200 a little bit difficult to exit the side part.
Mm-hmm.
So sometimes we may use field like field STA because it's a taper tip.
Mm-hmm.
If there is already a channel between the super chamber and the true lumen, the field XC wire also could cross. Okay. If the palette 200 wire if still couldn't cross, I
Mm-hmm.
may from the distal hole to
Okay.
do bobsled.
Mm-hmm.
Okay. Okay.
So like Professor introduced, we can see that this is, a stake and swap technique. So this Pilot 200 is, I think, one of the most popular wires for the ADR techniques. There are several things. Its capability of crossover is relatively strong, strong enough. And second thing is that this polymer is relatively favors for this ADR puncture to increase the capability of re-entry into the distal true lumen without causing very big hematoma and damage to
Good
the subintimal
explanations.
space. And also, there is a question from the audience that why do we perform these anti-grid EDR techniques without trying the, just the simple parallel techniques? Like we just introduced the information from the CT reconstruction. There is a relatively long diffused CTO segment. So anti-grid parallel techniques is relatively with a low success rate because this is a JCTO score 3 case. And also with the CT Rector, scoring system, this is a CT Rector, 3 to 4 case, which means it's an extremely difficult CTO case. So I think that the anti-grid parallel techniques doesn't, means a lot in this kind of situation, especially during the second attempt of this case. Although the I mean intravascular imaging,
I think it's a little bit difficult to come out.
yes,
We may change the place. Okay, epicrenal to use contralateral angiogram to recheck the position of the.
yes.
Okay.
I think that confirming the distal reentry site is of key importance.
Okay. I think we should advance a little bit
Yes,
further.
because we can see from the collateral, I mean retrograde angiography that the reentry site might be a little bit proximal to the second diagonal, and which means that we could, I mean, engage the stingray balloon a little bit further to increase
Gaia third.
the reentry successful rate.
Gaia third.
So as you may notice that this patient is a relatively young patient. He's only 41 years old. However, there is a lot of I mean risk factors, so which explains why he's a triple vessel disease. You can see that 3 years ago, he performed an stent in the circumflex due to the myocardial infarction, which explains relatively old ST segment in the inferior lead. And also we may pay very close attention during this relatively long and difficult CTO procedures of the other vessels. For example, we may, watch very closely the blood pressure change, not only from the antegrade system, but also from the retrograde system. And also from time to time, we need to test from the antegrade and also retrograde to check the big DAC, the flow from the circ, to make sure that everything is okay, everything is stable. What's more, what's the nearest ACT value? Okay, which means it's enough.
Please. Look like very close to the.
Yes, yes, maybe so.
Okay.
Yes, we change a little bit our strategy to check the position of the wire.
So orthogonal view. Okay. And you? Other. Okay.
So, Professor Lee, do you think you want to engage the Gaia wire a little bit further to?
Sorry.
Okay, I think that one of the most difficult issue of this patient is that the collateral flow from the RCA is not sufficient enough. To make a very clear identification of the distal true lumen.
The wire should be in the subintimate space.
Okay.
Okay. The feeling told me subintimate space.
So maybe it's potential, re-entry point or something.
Test a little bit. Okay. Could be as
yes,
like
or maybe yes.
Okay.
Or maybe it's in the track from the maybe
advance a
3 months ago attempt.
Here. Okay. Advance a little bit further. Okay.
The second diagonal is still at the distal part of this stingray balloon. So re-entry at the current spot doesn't influence too much of the perfusion of the myocardium from the left ventricular. So according to the CTO algorithm flow chart, we can see that this CTO case is a blonde tape. Relatively long. Over 20 millimeters CTO segment.
Okay.
And also that we can see it's a favors for ADR very much, which explains our strategies.
CT where, please. Okay. So let's choose
So we are switching to a relatively distal part of the stingray balloon to make a second attempt of the ADR wire puncture.
okay.
So like the demonstration of Professor Lee, I think there are several
value
things very important
in the-
during the anti-grade ADR techniques. Like I just explained, the right position, of the re-entry point is of key importance. So we may check which is the right
Yeah.
re-entry point from the
value,
retrograde, angiography to make sure that we will avoid all the main side
value
branches, and also we can see very clear the distal,
in one line. Okay.
the distal retrograde flow to make sure the re-entry point,
Okay.
which means the true lumen.
Okay. On the back, please. Okay. Can we see? Not in one line.
No, maybe no.
Okay. Epicaudal.
Yes.
Choose the angle.
So we can see that we are trying different kind of projections to seek the best,
Okay.
projections.
RU. Yeah. Okay.
Mhm.
I see. RU. Auto, please. So in this direction,
Yes, I think this
should
is
be one
yes.
line.
Mhm.
Okay, that's fine.
The bilateral side of the stingray
Andrew,
balloon
please.
is, coexist into the point line, which means that the whole balloon is at a horizon, situation, makes us
Okay.
relatively easy to identify the puncture direction, which hole we are cruising, and which, direction we are trying to go.
Okay. So
I think that the audience is quite interested in our case. Whether is there any questions from the audience?
new palette 200.
Mhm. So we are still using the pilot 200 to try to puncture into the true lumen.
And we should enlarge the picture and use this.
Okay.
That.
So Professor Lee, do you think the calcification within the CTO segment is an issue of this, puncture difficulty?
Okay. Okay. Okay.
Okay.
So where is the true lumen?
I think that from the collateral angiography, I think it's, for me, maybe it's from the upper side. Okay.
Okay, end your game. Okay. Okay. Stop. Not very clear.
Yes, because there is some, mild diffuse calcification, which, influence the identification of the distal entry point. So maybe I
Do
think
you
that.
think a straw may help?
Mm-hmm.
Okay, let's withdraw with the pump
Mm-hmm.
for relatively long time.
Mm-hmm.
Okay. Withdraw. Because we couldn't see.
Mm-hmm. Yes.
Okay. So because here is real calcification. Couldn't see. Okay. Where please? Give me the wire. Okay. Where please? So if the distal tournament is large, when the the puncture wire come into the tournament, we could use stick and drive strategy. But if the distal tournament you couldn't make sure if the wire coming to the distal tournament. Sometimes we may try stick in the swab.
I think that for the current situation, stack and swap should be a good choice because it's relatively difficult to see the re-entry point.
Okay.
The primary tenet of the non-CTO PCI is to avoid wire penetration into the sub-advantageous space as this may raise the plaque. And also further impairing the coronary flow and potentially causing myocardial infarction.
Please.
However, a significant leap in CTO PCI success rates would come from the unconventional approach.
Okay. Hiding no thrombus. And at present, I think we already tried ADR, ADR technique, but I think should be already some hematoma formation and the distal movement a little bit collapse. So if we still try integrated approach, because at first my strategy is try to make the reentry zone at the proximal portion of the diagonal branch. Otherwise, when we recanalize IDD, may lose the diagonal branch.
这个好使了，现在
So
好
at
使了。
present, I think
现
we
在这个
should
好使，
switch to
是咱的这
the
个
retrograde approach.
Okay.
Okay.
对，
So
但是咱这
LAO, Greeno, please. LAO, Greeno. LAO, Greeno. Carawell with a workhorse wire, please.
Okay.
So just now we already see there should be some tight lesion maybe in the distal RCA. So I think we should check with IWAS first. Okay. Okay. Move the table, please. Move the table, please. Okay. Another CM wire, please. Give me a CM wire, please. So in order to use geo balloon the balloon trapping technique, I withdraw the Gazeta. And another workhorse wire, give me please.
Okay, as
I
a
will check
doctor.
the RCE first.
Okay.
If there is severe stenosis, if need to be treated first. Okay. Okay, must make the blood flow back freely to avoid thrombus formation. Okay. Workhorse wire, give me the workhorse wire, please. Okay.
So like Professor Lee introduced that we are, switching to the retrograde approach. Since the antegrade, stingray balloon-based ADR techniques, they doesn't have a clear view of the distal reentry site due to the maybe potential antegrade hematoma, and also that we can see antegrade parallel techniques doesn't make very good progress. And also, if we perform these ADR techniques in the relatively mid or distal part of our AD, we are taking the risk of losing relatively two or even more relatively big side branches, which
Andrew,
is not good promise for the good prognosis of the patient. So now we are switching to the RCA, and first we can see there is a relatively long diffused plaque distribution along the RCA.
Look better, I think.
Yes.
Okay, Carawell, please.
However, we need to pay attention to
Give me
the
a two balloon.
distal bifurcation of the RCA.
Yeah. No, two balloon, please.
I think after some natural, it could get better.
Yeah. Diffuse lesion in the RC, but we could try. Sometimes also there is no very good collateral, septal collateral channel could be seen by the angel. There is septal wire surfing could help us to cross.
Yes, and also there is one
New
how to
Sion,
say,
please.
compliment from the audience that keeping the wire in the septum branch is a good help in
well.
maintaining the whole system of the retrograde system stable. So we can see that with Gazeta and also the wire in the septum branch, the whole system is stable and offering enough support for the following procedures.
So for the ADR technique, really the indication, the optimal candidate choose is of great importance. Efficient. So for the very large and okay, RU please. This is the restroom or seal. This one. Yeah, that's why are you seal? Okay. RU. That's a little bit. Okay. Sometimes it's too while surfing. Okay, okay.
Yes. How about some? Yes, one a bit further.
Okay, now.
Yes. Yes, I think this one is a potential one. This is a seal
Okay.
one, right?
Yeah. Give me some net contrast. Small range contrast, please.
So we are going to perform a
Super
selection.
selective injection.
Yes.
Yeah. Okay. So okay. Thank you. Stop, please. Okay. So before we inject, we must withdraw to see if there is a continuous blood flow back. We can see
Yes.
the blood flow back. Otherwise, we couldn't forcefully inject. Oh, I don't think this is a good. Okay, give me the CM wire, please. So at first, I already said no, very good.
Yes, collateral flow from the distal
Yeah.
RCA. It seems that
By
the
septal wire surfing.
yes, it seems the contralateral flow from RCA is a combination of several very small collateral chambers that form the angiography from the retrograde. It's not, I mean, good enough, which means to reach the CC level 3 or even better collateral flows.
Yeah.
That's why we are trying the anti-grade ADR techniques first, not the retrograde approach on this case.
Okay, give me where. Test a little bit. Okay, I don't think so. Test a little bit.
The far ending of the RCA is relatively long, but it doesn't seem to be connected with the septum collateral channel.
Just to try the surfing.
because from the bilateral angiography, there is no very clear CC level 3 or above level collateral channel.
Okay, do a super selective angio.
Mm-hmm.
Contrast, please. More, a little more. Okay, could be more, please. Contrast.
Okay.
Contrast, please. Okay. Sometimes we also could try the postlateral branch
Mm-hmm.
and postlateral branch, but for the postlateral branch, okay, how about the proximal one?
That's a choice, but it's not a guarantee
Yeah,
of
okay, that's fine.
good channel.
Okay,
Yes.
give me the CMR, please.
It seems it's connected to some septum, but it's not. It's unknown is whether usable or not.
Please. Okay, should be this one.
Mm-hmm.
Should be this one. Okay.
Yes. Yes. Mm-hmm.
But
It's hard to say where its exit point.
yeah, maybe in the proximal portion.
Yes.
Yeah, not really. Okay.
Thank you. Copy that.
Okay. Okay.
Mm-hmm. Yes.
Ah. Yeah. Stop. So I think we could advance a little bit the microcatheter and do a super selective injection. Because we already could not. Okay. About here. Okay, give me the contrast, please. So why I don't like to use a retrograde approach for this case? Water, please. Benign water. Benign. Okay. Install. Okay. Because really maybe some Doppler channel, but more close to the distal cap or even okay, we can see the blood flow back. Okay. Okay. Okay.
Yes, it's connected. Yes, to the
AP cranial. I think. Yeah. I
Thank you.
think we are already in the right direction. Okay. Okay.